associated with immorality. So when we have the right information and we sensitize and get non-judgmental services in our facilities, then that means we're going to yield. But if we still campaign and not give the non-judgmental, confidential, and compassionate, then we may not get what we're looking for. Yes.
You know, the release of this story by Elizabeth in itself raised an alarm, you know, lots of fears. And I could see on social media people, you know, alarming each other and alerting each other and telling each other, you know what, stay woke, chunga sana and all that. How do we get ourselves from that phase of stigma? How do we get ourselves from that phase of not having knowledge and having knowledge? Just how much needs to be done in terms of, you know, all these public health campaigns that perhaps would be different to tweak the whole situation?
One of the most important things to be done is to alleviate myth and misconception.
Yeah.
If we tackle myth and misconception and we do thorough education, health education, we pass knowledge on what is the expectation, because actually someone will tell you that oral sex has lesser chance of getting STIs. So the moment we address all the concerns and all the issues which are there, and good advocacies, and we have good channels, because we can do all this, but are our health sector welcoming? Because advocacy will be done through public health, everything will be done. But when you go to the hospital, you don't get the service. Actually, that's what now will make people to get tired, deter people from going to the hospitals. So with campaigns, education, and alleviating the myths, we'll achieve what we need to achieve.
Okay.
Because actually, from where we are, we started small at AHF Mathare Clinic. And as we are going, the numbers are growing slowly. So as we keep doing the advocacies and the education, we see numbers are coming up.
Okay.
So it is a possibility.
All right. So we talk about sexually transmitted diseases or sexually transmitted infections. What are some of the misconceptions, you know, top of mind that perhaps people would have that you would think would be necessary to be scrapped off so that moving forward we embrace the need for screening, we embrace, you know, the need for shunning, stigmatization and all that?
To start with the first one, which I mentioned before, is we associate STIs with promiscuity. That if I go there, the only thing they'll think of me is I'm promiscuous. Okay. Or maybe I'm a sex worker. Then they believe also I need to have symptoms for me to think I have STI. So first we have to remove these and tell people that not a must. You should not wait for symptoms.
But most of the people will tell you that when they get to health facilities for help, you know, in such cases, these questions will be asked to you. Why have you come? When was the last time you engaged? Why do you think? Why do you worry? Why do you think it's necessary for us to take this screening? I mean, when it gets to that level, how do we then get the confidence that perhaps I could just walk in even though I do not have the symptoms?
In treatment, we have 3 sections.
Okay.
One is where the patient presents with the symptoms they have. Then as a healthcare worker, I will do examination based on the findings. Then based on the findings, I will tie both history, because in history taking, we say that we use the 5 Ps approach, whereby we are concerned about the practice, partners, pregnancy intention, past histories, and then from there, we do physical examination. Then I tie all these things together. Then now I will have an impression of what you might be having. Okay. I might suspect syphilis. I might suspect chlamydia. I might suspect gonorrhea, basing on the symptoms and the examination findings. Okay. So basically, the questions we ask, it's part of treatment. So when the expectation of many of the patients is that if they come to the facilities, they shouldn't be asking any question.
And if the questions